All right. Thank you everyone again for coming tonight, despite the rain. Actually, I think it might be sunny out now. But welcome to, I think it's our fourth Fireside Chat. My name is Giali. I'm the founder of Soma Health, and we are building a consumer neurotech platform. We're still in stealth, but follow us on the socials. Check out our website. We're going to actually go into beta testing soon. Today, I'm super excited to have Dr. Emilė Radytė join us. She's joining us, excuse the siren, she's joining us from London, although I guess she's also moving here soon. And she is the CEO and founder of Samphire Neuroscience. And I'm super excited to have her here. We're going to talk about her story, and hopefully everybody has questions, and we can make it kind of an open discussion. So yeah, we'll get started at that. Welcome, Emilė, or Em.
Thanks so much for having me, and thanks everyone for making it out during the rain.
So, I always like to start these by kind of tracing back to how you got here. You know, even before Samphire, even before your PhD, what was your first encounter with neuroscience, and what was the first thing that kind of like really fascinated you, that kind of motivated you to go into studying the brain?
Yeah, I grew up in Lithuania, and in Lithuania, neuroscience wasn't a field when I was graduating school, and wasn't ever anything that crossed my mind. I was interested in a lot of different systems, but didn't even know that you could study a single brain organ as it would be. I was always like, biology, psychology are interesting, but, studying one organ would have been strange. And I think, honestly, I came to neuroscience relatively late in my undergraduate kind of years, where I worked as an emergency medic for about 4 years, so kind of on the front lines of seeing everything that's going on. And essentially one day I just realized that of all of the cases that we were seeing as a service, about 50% of them were actually psychiatric emergencies. So, you go through this intensive training, learning how to deal when someone bleeds, someone has a traumatic episode, or whatever happens on the streets, like everything that you expect emergency response for, like even delivering births and etc. But that 50% of the cases we were responding to were things like panic attacks, a suicidal episode, unfortunately, or someone, rape stories and things like that. And those are stories where you rock up on scene after someone has called 911. You're someone with professional training. You come up, and there's literally nothing you can do. And so that put my head spinning as someone who was always fascinated by science and things like that, of it's insane that this is still happening. Psychiatry is still the only field that is diagnosed by a book, as opposed to having any normal test, or any test of anything other than, a story. And so got really interested in neuropsychiatry, so the way of looking at the brain and understanding how that can impact outcomes. And to this day, I am trained as a neuroscientist, but I'm first and foremost, I think, a neuropsychiatrist. I really want to understand how the brain impacts the way we feel and behave. And yeah, I think that was kind of the most initial thing that got me really fascinated about it.
Does that relate to when you were doing your undergrad at Harvard, studying both neuroscience and anthropology? Tell me a little bit about that pairing. I think you were the first person to do that at Harvard. And how do you think anthropology influenced your understanding of neuroscience and vice versa?
Yeah, you did good background research. Yeah, so I got really interested in the brain, studied neuroscience, and then, I don't know, for me it was just very much like, you can't understand the brain without understanding what the brain makes us do. And what brains make us do in societies is always going to be studied at the anthropological level. Anthropology is actually a field that has studied, human behavior, and only later were we able to break it down into what actually happened in individual brains and develop things like psychology and things like that. So I think for me, it felt like those fields came very naturally together. But yeah, I was the first person to do a joint degree in it, because it's a particularity of the way Harvard works, that it doesn't allow you to double major into things. So if you wanted to do neuroscience and anthropology, you needed to join them up, which means you needed to study them together. And that was a very interesting exercise, realizing how difficult it is for scientists to talk to anthropologists or social scientists, and the exercise of social scientists trying to communicate their methods of knowing and their methods scientific method per se to actual scientists and stuff like that. So I think other than neuroscience and anthropology, doing a joint degree between fields taught me how communication is really important across different disciplines, because that's where like the interdisciplinary research actually struggles. It's like communicating what you get the best from one field and what you get the best from other field, as opposed to kind of using the methodology of just one of them as well. So that was really interesting.
What do you think was the most interesting, maybe anthropological effect that you learned about that was maybe kind of directly related to neuroscience itself?
Yeah, so my thesis was on language of thought, which is an old kind of hypothesis around the fact that thought might be modeled as language is, and kind of modules along the way. And we had done a pretty extensive MRI study to test that. And I think that was interesting because from the anthropological side, there was a lot of like semiotics and like kind of bringing in the linguistic anthropology side, which was in my original training. So I think that was a cool way in which anthropological studies of different languages, different language structures, different language modules really pushed forward our scientific thinking of what language of thought could mean, because initially it was a theory fully based on a Western view of English language, so like kind of subject, verb, object or whatever. But when we studied a lot of other languages, including my professor specialized in God talk, so that's the talk when people seem to have like epiphanies in churches and seem to speak in tongues. So understanding what the structure of speaking in tongues is and whether we can apply that to, kind of a seizure or epileptic activity. So lots of different things there, but it's places where we can observe human behavior in the real world that anthropologists have studied through language and then try to apply that to the way we form hypotheses in the scientific field. So.
Wow, that's super interesting. So across different languages, was the framework similar or very differentiated?
Very different. And to be honest, at the scientific level, you need to kind of pick the one that you want to test, because you can't test like all different ways of doing languages. So for example, English language and a lot of the kind of Western languages are very much what I described, kind of subject, verb, object. But for example, Chinese or Mandarin is very much like icon-based as well and kind of concept-based as well. Speaking in tongues usually was also like fluency phase. Like a lot of it was actually more conceptual. I would say it was more similar to that as opposed to structure and things like that. So in the study of MRIs, we just needed to pick one model and test that. We couldn't just test which one of them is correct, and the one we picked was not correct. And we picked the Western one. So that wasn't how thought is made, and it could be that there's just no such thing as language of thought, or we picked the wrong model. TBD. Yeah.
This is actually very relevant to my PhD work, which was looking at semantic memory and like how language around semantics mapped into the brain. So
that's awesome.
We can talk about that offline.
You probably did a good
That's why
iteration.
I just went down that rabbit hole. Okay, then you went to Oxford, did your PhD. Tell me a little bit more about your thesis work there and how both that work as well as maybe some of your work in undergrad influenced what you're building today.
Yeah, so that was kind of increasingly and directionally linked to what we're talking about here today. But my PhD thesis was on brain stimulation, so transcranial magnetic stimulation, which is a form of stimulating the brain in specific brain areas that is a validated treatment for depression, an off-label use for OCD, and has been trialed in a lot of different other conditions as well. And essentially I was looking for optimization protocols for that for different people with depression. So we know there are subtypes of depression. Some people are more sad, some people are more anxious, some people might have general emotional dysregulation on top of their depression, and we were seeing whether different protocols would be more effective for different people based on different things. And essentially worked on optimizing those protocols with some new machines that I got to play with that could do stimulation protocols that were never tested before. And as I was working on depression, I realized that a lot of the patients I was dealing with, or participants in the research, were women. And as part of recruiting them, I needed to run these like very extensive interviews of understanding their mental health and what brought them along, so we could understand their subtype very well, because everyone gets a diagnosis of depression, but we were interested in the one step deeper, like what type of depression is it? And having the vast majority of our participants be women, we realized that actually a lot of their depression started in hormonally relevant events. So everybody kind of now knows about postpartum depression, so that's not a surprise, getting depression after having a child. But the stuff that started coming up very much was perimenopausal anxiety was one of the biggest ones we're seeing, and perimenopause can start as early as 35. So seeing women that are like, 37, 38, and they're like, I don't know, something weird was going on. I stopped using hormonal contraception and then like started getting depressed. And also premenstrual depression also started coming up. So the feelings of depression in the 2 weeks leading up to your cycle, or the aggravation of depression during that time. And that kind of really struck me as someone who spent a lot of time as a neuroscientist working alongside psychiatrists, that not a single psychiatrist I knew would ask a woman patient when her period last was or whether they're perimenopausal. Like, it's just not a question they do. And seeing the pattern over and over again, I was like, that's really interesting, because you literally have the woman as her own control. Initially, that was purely like an academic challenge to me, where I was like, if we have a woman who is depressed for 2 weeks of her cycle and not depressed for 2 weeks of her cycle, this is literally like a scientist's wet dream, like of having the brain compared before and after. And I think realizing that like it actually hasn't been studied at all was really shocking to me, and that's what led to me starting Samphire a couple years later.
And tell us a little bit more about Samphire. What does it look like today? Where did you start? And maybe kind of walk me through maybe the first moment that you had, okay, this is the thing that I'm going to build, and how has that evolved over the last 5 years?
Yeah, for sure. So, as I mentioned, I was kind of in and out of the lab working with these brain stimulation techniques that are amazing for depression, but were not at all adapted for women. And then I realized that, there's this technology that's been very well studied that needs further iteration and adaptation for women. But if we could make it something that could fit into their lives, namely be accessible from home, be affordable, be safe to use from home, easy to integrate into their lives, and know how to use it with their cycles, that could be really exciting. And so essentially Samphire started from the idea of building neurotechnology for women to transform what the quality of life looks like. And the conditions we first started looking at is PMS, or premenstrual syndrome, and menstrual pain, because those are the ones that are most ubiquitous. Most women will experience at least one of those symptoms throughout their lives, to varying severity, but about 30% of women are impacted enough so that it impacts their everyday productivity, as well as performance and pain perception, et cetera. And so we set out to build a neurotechnology tool for them, and the initial iteration was literally like a very makeshift bit of electrodes that I would put on women's heads, like use a little kind of headband to put it on top of their heads, and then stimulate their brains to impact their symptoms of mood and pain associated with periods. We got amazing feedback, mostly that it needed to look better, but other than that, this was great. And then we spent a couple of years iterating it, running clinical trials, and we're the first ones, to my knowledge, to run neurotechnology in women's health clinical trials. We got medical clearance in Europe and the UK as the first hormone-free and drug-free medical-grade treatment for PMS and menstrual pain. And now we're hoping to get our clearance for PMDD treatment, so premenstrual dysphoric disorder, that form of depression before your period, hopefully over the next few weeks. And then endometriosis-related chronic pelvic pain very soon after as well. So kind of looking to expand what neurotechnology can do for the general well-being of women. So far, still staying around the period space, though we are seeing increasingly a lot of interest from perimenopausal women who notice a similar kind of mood changes. So we're running studies and expanding in a couple of indication areas as well. But yeah, so I think in terms of iteration, our mission of delivering neurotechnology for women hasn't changed. I think the method and the way we thought about it, so kind of making sure that we have personalized algorithms that work with your cycle, or work if your cycles are irregular, or if you're on hormonal contraception, like taking a lot of that into consideration was important. And what we didn't realize, because it's so poorly studied, is that most women with PMDD also have ADHD or other forms of neurodiversity. How do you take that into account? Do you need to study that separately? Can you do citizen science with people on our platform and things like that to push the envelope for women's health research further? So those approaches have evolved a lot over time, and we didn't see them coming. But at our roots, we stay true to delivering new technology for women.
Super amazing mission. I want to come back to this personalization point, but really quickly, you're using transcranial direct current simulation. Can you, high level, explain the mechanism through which you can zap the brain, and then directly influence, pain, pelvic pain for menstrual cycles, and even kind of perimenopausal symptoms?
For sure. So again, don't know what backgrounds the audience comes from, but at a very high level, the brain operates with two main mechanisms, the chemical and the electrical mechanism. So chemical is everything that we talk about when we talk about neurotransmitters. So things like serotonin, dopamine, GABA, glutamate. Those are all examples of neurotransmitters that are chemicals that impact brain activity. At the same time, the brain also runs on electricity, which is all of our kind of brain networks that operate together and influence the way we think, the way we behave, et cetera. And those operate at different levels operate together and like kind of always intermingle as well. And so essentially brain stimulation will always rely on that electrical pattern kind of directly, so that changes the way our brain communicates. When it comes to brain stimulation, especially the type of stuff that we're talking here, so non-invasive brain stimulation, we target specific brain areas associated with specific networks. So for mood, we target the dorsolateral prefrontal cortex, which is an area in the brain associated with essentially switching between the default mode network, which is active when we're kind of passive, and attentional networks, as well as salience networks, so networks in the brain that allow us to understand what's important or what to pay attention to as well. And so essentially we know that those types of nodes, like the dorsolateral prefrontal cortex, they seem to be underactive in people who have depressive symptoms. And so we know that when we stimulate it, we essentially strengthen it so it can recreate that balance in the brain and allow better prefrontal, so top-down control over the limbic system that manages emotions. And it just so happens that in women leading up to their periods or in response to hormonal changes, for some women, the ones who experience these symptoms, the prefrontal cortex becomes unbalanced and that dorsolateral prefrontal cortex isn't able to control their emotions that are deeper in the brain and the limbic system, and so we restore that control. So in some ways it's like an indirect way of helping your brain manage its own emotions, which is why the way you use it is in the couple of days leading up to your period, so you kind of train your brain to anticipate that emotional change. When it comes to pain, that's a very interesting mechanism that is actually much less understood because the mood mechanism has been studied for 30 years. It's so well known in depression, so well documented, and we understand that really well. We just didn't understand it in women. When it comes to pain, we stimulate a part of the brain so we stimulate the motor cortex, which is a part of the brain responsible for action, but it also happens to have inputs into the posterior insula, which is the part of the brain that controls the pain perception threshold, which is essentially, I don't know, you and me might have different pain perception thresholds, but pretty much all women leading up to their period, their pain perception threshold actually increases. And so what's fascinating is that when your period comes, you're in pain because one, your uterine lining is literally shedding, so there's actual like pain, and then two, your brain is hypersensitive to it, so you kind of get a double whammy, which leads to severe period pain in some women, depending on that sensitivity. So when we stimulate that part leading up to your period, we kind of don't let that pain perception threshold increase, and what that means for most women is that you still feel a little bit of discomfort, but you wouldn't classify that as pain, and that's the difference in kind of, so that's why I say we're a device approved for for mood improvement and pain perception relief, because actually all of the pain is in the brain, which is another important aspect. And I do think that one thing that's worth noting, just because I do expect that we have a bit of a technical audience in the room, is that when we use the word pain, and this is my, I don't know, linguistic anthropological hat on, pain means a lot of different things. Like pain can be localized pain in your foot, it can be chronic pain. There's so many different types of pain, and we just happen to call it all one word. And we know that when it comes to the brain, it seems that different technologies work on different types of pain. So we just so happen to have a technology that works really well on pelvic pain. It seems to also work in endometriosis, but it doesn't work for sharp pain. So if you were using our device and someone stabbed you with a knife, you would still feel that pain. So it is quite selective in those areas, and we don't actually understand why. We are now studying it in fibromyalgia and in migraines and trying to understand what the limits of that pain we study are and to even give it some name. We call it primarily nociplastic or central sensitization pain that we think this is working on, but the pain research is still very much not sure where it fits with the brain research, and we're at the edge of understanding what that means.
There's so much to dig into there. I think maybe my high-level question across both of those mechanisms is, what are some of the variations that you see across individuals, and how do you guys think about that in terms of going back to your personalization point? What are the different levers that you pull to help standardize at least efficacy on different individuals with the technology?
Yeah, that's a really thoughtful question, because so we are the only device on the market and the only ones to have a patent to stimulate two brain regions at the same time, so both for mood and pain. And the reason that's interesting is because when we started off the studies, we were like, okay, we know that the mood mechanism will work because we studied it separately, and we know that the pain mechanism will work, but it just so happens that most women will have both period pain and PMS, so we want something that stimulates both. So we did that, we ran the study, and then we were actually shocked by how good our studies were at an average. So here we're still talking about general clinical studies, which essentially cannot be done in a personalized way, which we can chat about as well. But essentially in clinical studies, we saw that our results really outperformed everything we expected. And we dug deeper into the data because, you're always suspicious when everything looks too good to be true. And what we realized is there's probably a gestalt effect between the two. So the fact that you've regulated your emotion means you're less anxious about your period pain coming. So ironically, your pain perception threshold doesn't rise as much, so you're not in as much pain. And similarly, with ongoing periods, if you're in less pain, you're less anxious about your period, potentially feel more in control, and your mood doesn't change as much. So there's an additional psychological effect emergent from the fact that we stimulate both of those things, and that's something that we have seen across our population. So I think as a general rule, I'd say, so we have about 1,500 people using our device now, and it's kind of growing every day. But one of the things that we notice is that I'd say about 30% of our users have endometriosis, so very severe ongoing pain, and then some other comorbidities with it. About 30 to 40% would have PMDD, so very severe mood symptoms, and then the rest of them will have some combination of PMS, period symptoms, and everything across the board. And we generally see that actually what is also interesting about our technology is that with most medication, the more severe your symptoms, the more of the drug you need to take. That's not necessarily the case with neuromodulation, because if we go back to the mechanism, we're changing your perception of things. So imagine perception as kind of a barrier, and it doesn't matter if it's ignoring 70 molecules or 3 molecules, once that barrier changes, it's actually a little bit severity independent. So I think that was the most surprising bit, that we seem to be able to do relief at different levels of severity. And obviously the threshold being that it's severe enough to impact your life, because otherwise you wouldn't notice the difference. But I think that was the most surprising thing I learned. And then the bit that drove us to personalization, so we can't personalize the level of stimulation we give to each individual person, so the actual parameters, because those are regulated and tightly controlled from a safety perspective, and because we're a regulated device, that's what we kind of prioritize. But we can do how many sessions you do per day, how do you time them with your period, because we know that's impacted by kind of hormonal fluctuations and stuff like that. We personalize it based on your condition profile. So we now have studied over 1,000 women with endometriosis, PMDD, PCOS, understanding how those patterns impact them. And so essentially, the more information you can give us, the more we can personalize it to you. You can choose not to give us any information, and all of it is de-identified. And then we use that to recommend what the best pattern will be for you. And the most important and exciting aspect of our algorithm for me is the fact that it's fully dynamic. So as you progress and you track your symptoms, we can reduce the number of sessions you need to change your profile as your symptoms improve as well. And I think that's just a nice way of doing medicine in kind of a fully responsive way.
Well, because this field is so new, and like you said, you're really kind of pushing the boundaries of what we do with neurotechnology, especially for women's health. What has been maybe some of the more challenging parts of this? I can imagine there's a lot of different things across, the science, the R&D, the productization. And what do you think in terms of educating the user on something that they have to wear that stimulates the brain that's supposed to help downstream? How do you go about that education piece?
Yeah, I mean, you're nailing a couple of things. I think in terms of what's difficult, there's all the expected things, we build hardware, we build software, we're a regulated device, I think there's a lot of things that we share with other founders. I think what's been quite unique to our journey that is worth pointing out is the fact that this is so new that most regulators and counterparties that have a lot of influence over, be that our go-to-market, our market access, or whatever that may be, they also don't really understand our space. So for example, we've been talking to the FDA for the last 3 years, trying to understand, what evidence do you need to see from us to say that we're an approved device for PMS? And they're like, well, run a study on women with PMS that have no comorbid conditions. So a woman whose only problem in life is premenstrual syndrome. We're like, okay, not super realistic, but we'll do it for you. How do we include someone in a trial that only has PMS? And they're like, well, use the diagnostic criteria for PMS. Well, you'll be pleased to know there are no diagnostic criteria for PMS because it's not a clinical condition. It's a stage of life. And so as a result, we're like, we don't even know how to run a trial to satisfy this, because in our European trials, in Europe, there is actually a standard for diagnosing PMS, which is what we use, but it's not recognized necessarily in the US. So how do you prove you've fixed something that isn't recognized as a problem? And so we go back and forth, and to their credit, they always bring in these interdisciplinary experts that have been really helpful, and we're working with them, but we need to work with them to set the standard and then implement it together. So I think that's kind of a weirder thing we didn't expect to happen. And when it comes to educating the user, My thesis of the world is that the world is increasingly moving towards more personalized medicine, which I don't think will come as a surprise to anyone. But two is that consumers no longer want to be treated as dumb and view doctors as infallible, fortunately or not. And so as a result, a lot of people are taking matters into their own hands. And I would say our users are incredibly well educated about their health. Like I always say, they're the experts of their own experience, because the vast majority of them, unfortunately, have been completely ignored by the system. Like they come in and they need to advocate for their pain being real, their mood symptoms being real, etc. And so as a result, I found that we have amazing early adopters, but what will be the barrier to kind of crossing that general kind of awareness threshold is just going to be the recognition of the fact that women's pain and mood matters. Because once that happens, I think the technological barrier is less. Like, you know, I feel like GLP-1s have standardized people injecting themselves, which is a weird behavior. So the fact that, like, you know, now they need to put on a headband that does things feels a bit less weird. But I do think that the bigger education barrier is not going to be the neurotechnology, but the acknowledgement of women's pain, unfortunately.
Yeah, I really love that point about just the cultural appetite, I would say, anthropological, one might say, of accepting new modalities for addressing, personal health problems. One of the, I think, high-level questions that I had for you building in neuromodulation is, do you see yourselves kind of expanding beyond TDCS into other modalities? Do you see yourselves expanding beyond women's health into, you know, health for other types of conditions or populations? Like, how do you think about the long-term vision of Samphire?
Yeah, I mean, again, my view of the world, having worked with neurotechnology for, 7, 8, 9 years, is that there are 3 areas where I think neurotechnology or non-invasive consumer neurotechnology can truly be life-changing as a technology for so many people. I think one of them is performance, which is where you'd see most of these TDCS kind of neurotech devices popping up for different reasons. And that's probably going to be the case, but I think that it's very hard to take a person that's operating at 100% and be like, you're going to be 120%, because people are going to be like, wait, this is my 120%. That's kind of disappointing, and then people stop using them. So I think the performance space is one area. I think the other one is depression. That's the field that I came from. I think there's such unambiguous clarity for me that neurotechnology will have to become at least a first-line treatment for depression, because antidepressants work for a lot of people, but they work on a trial and error basis. Like, there's literally, the psychiatrist looks at you and prescribes you an antidepressant that they think you should be on, and then you spend 6 weeks and then get a new one or get a dose increase. So it's a very trial and error thing. So if you're trial and erroring something, you should trial and error something that influences you less, which is kind of neurotechnology is like less invasive because you don't have a drug flooding your entire system. And the third category, I think, is women's health. And the reason why I think that's the case is because women disproportionately suffer from long-term chronic conditions that impact quality of life, but don't necessarily, bring them to the hospital. So they struggle. So they need something that is available at home, ideally not super invasive because of hormones. So it needs to be accessible both when they want to get pregnant and when they don't want to get pregnant. It needs to be kind of viable across the reproductive lifespan. And it needs to be something that is effective for both mood and pain symptoms, which I think cover the vast majority of women's health conditions. And so essentially, I'd like to own that third category because I think that it makes just so much sense. Like, I just don't know what other player that could even be. Most pharma has discontinued most of their women's health programs anyway, because they realize that everything starts messing with hormones, and that is not great for women. So I think I would see us expanding in other areas of women's health. Going beyond women's health, I think I'd need a good argument, but I will say that when I say women's health, I mean conditions that disproportionately impact women. So things like migraines and fibromyalgia for me are very squarely in that territory as well.
Yeah. When you think about the last 5 years of building in neurotech, what's something that maybe you've had to unlearn from your previous life of being a researcher?
Everything. I mean, you've been a researcher as well, so probably feels a bit relatable. But I think the bit that it's never going to be perfect the first time. Like, we were building a medical device, which essentially you need to submit, this is what the medical device will look like, and you can't iterate from there. And I was like, oh, this is perfect for, like, a perfectionist, because you try to get the best device done. But even now, like, we've recertified already, like, twice. And so I'm like, it's just always keeping in mind that things can always be better. And it's always like, you learn so much from the way that people actually actually use it. And I think the funniest story was, so for the European certifications, it's very, very extensive. But one of the reviewers told us to add an instruction into our instruction booklet saying that you shouldn't use this electronic device in the shower. And I was like, this feels a bit weird. Like, surely people know this. Like, should we also like specify, like, don't use it in the pool and everything? And they're like, well, the thing is, like, you need to account for every scenario possible. You need to think it through. And so the first time you do the thing, you're never going to evaluate every situation that could happen. And so I think that was just like a small example of like so many things that you learn as you iterate along the way. So I think learning that it's not going to be perfect the first time was a big one. And then I think in research sometimes, less so in science, but definitely in anthropology, there's this idea that you can discover things alone without a team, and I think that's just fake. Like there's nothing, like no big thing has ever been built alone. And so I think like changing that mindset has been very important and actually has been to some extent limiting when we work with academics, because we work so much and all of our research is done with academic partners. And so speaking to them and being like, hey, we're a team here, like we don't need to, like, you know, we can all be on this paper and all like kind of work on this protocol together, and this doesn't need to be like this proprietary thing, has been a thing to unlearn as well.
Yeah. Maybe last question here. I'm trying to pick one because I have so many. I guess maybe to leave the audience with, you know, the world of Samphire. Walk us through what it's like to be the end user today, and where do you envision that going in the future?
Yeah, so an average user of our products, so Nettle in Europe or Lutia in the US, you order the device, it comes to your house, and ideally before it comes to your house, you have used our app to kind of track your cycles, track your symptoms, etc. And the longer you have tracked your symptoms with our app, or you can import them from literally any menstrual tracking app or Aura or whatever wearables you have, then you get your device, you sync the headband, so it looks like a black headband. I actually don't have one with me, but you can find it online. So then we tell you, okay, your period is coming up, this is your profile, this is your personalized protocol in the way that you should be using it. You should start using the device today. Then we walk you through a series of videos that show you how to use the device, where yours truly does some demonstrations. And then you put it on your head, and for 20 minutes you can do whatever you want. You feel a little bit of a buzz, and then you run the session for 20 minutes. For most people, I would say the first 5 minutes it's a little bit itchy. Have you ever tried brainstem?
No, actually.
Okay. Yeah, we need to get you on that.
Yeah.
But for the first 5 minutes, it's a little bit itchy, and then it goes away as your skin kind of gets used to it. And during the 20 minutes, you can do whatever you want, emails, life, whatever. We also have lots of breathwork and meditation on the app that is personalized to the cycle phase that you're in, can be further personalized based on your condition. We also have lots of educational stuff where we walk through the neuroscience, so what's happening in your brain as well, so you can do those during that time. And then when it ends, and then we notify you next day as well of when you need to use your session as well. So it's kind of that experience. And where I envision it going is honestly just more women using it and it being more part of the mainstream. For the vast majority of women, you only need 3 to 4 sessions a month in order for it to have full effects. Just as long as you do them at the right time, right place. So oftentimes you might start with 10 sessions just as we figure out where your symptoms actually sit, and then we modulate you from there. But yeah.
Awesome. Really quick round of rapid fires, and then we'll open it up to the audience. Just a few of these for you, and try to keep them short. So what was little M like, and what would she think of the M building Samphire today?
She was nonstop, and she would think that she hasn't changed a bit.
That's awesome. One thing you'd go back and tell yourself on day one of building the company?
Don't be scared of making mistakes.
Favorite brain region and why?
Favorite?
Brain region?
Ooh, prefrontal cortex is just the best.
Okay, this is a question about your EMS days. What has that taught you about the brain that no lab ever could?
That the brain is the best thing that happened to you and the worst thing that happened to you. And that brains bleed a lot.
Oh, wow. That's big learning. In the future you're building at Samphire, if the future of you're building at Samphire were a film, what would you call it?
Something like Happy Days. Like, I work on quality of life all the time, so it's like just smiley faces.
Awesome. Most valuable advice you've received as a founder in one sentence?
this is wait, what was it like? It's a marathon of sprints, something like that.
That's, yeah, great way to describe it. One book, film, or experience that changed how you think about the brain.
Interesting. Honestly, I'm a very textbook person. Like, I think the first time I read the, like, whatever Neuroscience 101 textbook I had, that completely transformed it for me. And probably it came down to this, like, chemical and electrical bit. Like, it hadn't clicked to me how complex the brain is as an organ.
If you could measure one thing about your own brain right now, what would it be?
I'd love to know how it varies on a day-to-day basis across the different cycles. So obviously, like, we spoke about the female cycles, but how does that interfere with my circadian rhythm? And like, I had a baby 2 months ago, like, how does that impact? So like, period cycles with postpartum cycles with circadian rhythms, I'd love to see what the, like, overlap in those curves look like, and what does that mean for my brain behavior as well.
Last question is, how did you feel the first time you tried on your own device?
Honestly, surreal, because I had tried brain stimulation before, but to try on something that you made with, like, your blood, sweat, and tears and feel like the effects that you expected to, honestly, it was probably relief, like, that it worked.
Awesome. Thank you, Em.
Thank you so much.
Awesome. And then maybe some questions from the audience.
I guess I get to be the first one. Thank you. Great conversation, by the way. I really like your insight about the pain mechanism impacting the mood mechanism. They're very much interconnected, obviously. So maybe relieving some of this pain in that mechanism could help with the mood and, indirectly. My question is, I'm not very familiar with the neuromodulation literature. Could you maybe speak a little bit about if there are any long-term effects where this neuromodulation can impact other mechanisms, other systems that depend on it indirectly, be it pain or mood or other things that, brain is highly connected. So are there long-term studies that looked into this kind of, periodic neuromodulation having some different effects on unintentional effects that are negative?
Yeah, great question. So yes, there are studies. I think the single study that ran for the longest time was about 10 years, where people were actually using neuromodulation most days, because that's the standard treatment for depression, where you actually use it every day. And they actually showed no higher likelihood of incidence of any side effects associated with long-term use than any short-term use. I guess a more satisfying answer to, so yes, there are no known long-term effects, and the longest study was about 10 years, but by times, like, if you were to multiply that by the number of sessions we do, that's actually the equivalent of like 60 reproductive years, which is obviously more than any woman would use them. I think the thing that's most compelling for me as a scientist, and comes back to the mechanism, is that we're actually what we call a medium-term neuromodulatory effect. So we're not rewiring the brain or taking over function. So if you think of an antidepressant, or the way that a lot of psychiatric drugs work, is they take over whatever function they're trying to do. And so that's why you become dependent, or can no longer necessarily function without them, or need increasingly high doses, because essentially we replace that chemical. So in depression's case, serotonin, and we replace that so you no longer produce your own endogenous serotonin. What's different with electrical modulation is that we never replace something that was there in the brain. We just kind of rebalance. Sounds very woo-woo, but it's true. You essentially like reroute where the electricity goes in some ways. So you don't, add something too exogenous. You kind of retrain the brain to do something by its own, which is actually the reason why over time you're more likely to need to reduce the dosage that you need, as opposed to increase the dosage as you need as you retrain the brain. So that's much more compelling to me, because as a long-term mechanism, I don't really see how, if it doesn't create dependency, how it could increase the side effects as well. I mean, obviously, I am a scientist, so there could be things that emerge after 50 years of using it or whatever. But for me, so far, it's definitely much more safe than hormonal contraceptives, and then antidepressants, and then painkillers, which are known to have long-term side effects.
Thanks so much for being here. I really hope you move here.
I'm here now.
Yeah. Oh, great. So my question is, you used the word first a lot, more than a lot of companies can. I'm curious, when you speak with investors, when you speak with regulators, how much of this is truly legible to them. And I'm curious if you can share more about how they're engaging with this. You know, are they thinking of you as a consumer neurotech company, or, you know, medical first, or I'm not even sure which categories might resonate because you're kind of blurring the lines a bit.
Yeah, I mean, you answered your own question, is that it is blurring lines, which is why it often doesn't fit neatly within, you know, the traditional definitions. And in fact, I think that's increasingly going to be the case to some extent. I should clarify, I see ourselves as a second mover in the field of neurotechnology. We're not the first ones to create a consumer neurotech product, and I mentioned a couple of other spaces, performance and depression, where I think they've been really successful. We are just the first mover of that in women's health, and I've kind of explained why I think that's a pretty unique space with the dual stimulation and everything, and, you know, very different population that no one else, I think, has understood. I think, to answer like more directly your question, most investors that engage well with us are people who believe that the future of health will look quite different, including the fact that one of the weird things about PMS and periods is that most women who have PMS and period pain think of themselves as healthy women, not necessarily as patients. So is it a medical product if most women are healthy? And I think we blurred the lines of what a patient truly is. And obviously some of the women we deal with are patients in the sense that they have endometriosis or PMDD, but many of them aren't diagnosed with it or don't see it, or they see it as a sense of who they are, not necessarily. Because if you live with periods for 50 years of your life, then it is who you are. It's not only your condition and things like that. So I think most investors would not engage with the depth of that necessarily, and frankly, they probably don't need to. But I think they need to believe in the world where like women do want to be in control of their cycles and the way they're feeling and have higher quality of life. Like, just because you will have another period next month doesn't mean that this one needs to be shit anyway, and you can improve the quality of life kind of as you go along. But it's not a clean story, but I do think we're slowly rewriting what a clean story in the space can look like.
Hi, thank you so much for everything and all the work that you do. So you talked a lot about management of pain and mood for endometriosis and PCOS patients, but as we know, detection and diagnosis of these conditions is really understudied, and most of the time, as you said, these women come in not even knowing that they have it. So I was wondering if you could speak more on the detection of these and how you see like the role of neurotechnology in this, and if Samphire would ever be interested in expanding in that direction, since it seems to be something that is a part of the bigger picture that you guys are really passionate about.
Yeah, great question. So in short, that's probably not a place where we would directly expand as a therapeutic, because fundamentally we're a treatment. And so for us, the perspective is like, so PMDD is an interesting one because it's essentially a mood disorder that emerges in response to normal hormones. So the only way that you can tell that someone has PMDD is because of their behavior and feelings and their brain. So that would be the only one. We're in the detection space where I think neuro could have a really unique angle. PCOS usually is associated with like hormone imbalances, and endometriosis has real lesions you can observe as well. So I think that's not the places where neurotechnology is best positioned to do. But because we know how big of a problem the misdiagnosis is and the lack of awareness, et cetera, is, we do lots of education, and we partner with all of the biggest charities in the world. So we partner with IAPMD, the International Association of Premenstrual Disorders, with Endometriosis UK and Global, to kind of work with those communities and educate them about both options available to them as well as how to spot the signs. Our app also, as I mentioned, can track symptoms, so we can flag if someone maybe wants to consider a diagnosis as well. That's always, we need to be very careful because you don't want to freak someone out who shouldn't be, but you do want to make sure that people are aware. We've partnered with companies like Hormona, so real-time hormone monitoring, or a couple of times monitoring, so we could identify PCOS as well as diagnose perimenopause is what they're certified to do. So we are partnering with people who can do that in a great way because we think there's so much collaboration there. We're working with, for example, algorithms of Aura, et cetera, and other wearables to understand what that identifies about your cycle phases and how that could impact. But there are people who do that so much better, and we're much more interested in partnering and servicing our end users in the best way we can than innovating in a space where I don't think neurotech is necessarily best positioned to give an advantage.
Thank you.
Hi, thank you. I think a brain-first approach towards PMS and PMDD makes a lot of sense, and the way that you described the two, like targeting both the emotions and the pain. But I think I'm a little more skeptical about its efficacy for conditions that are systemic, like endometriosis. You did mention you said 30% or something of your patients have this condition, and they found that it helped. I think I'm curious whether the patients that you recruit who have these conditions, do they have to be off of all other medications like birth control, anything else? Because also a lot of people with endometriosis have to be on something to basically not get periods, or they also have comorbid PCOS, and I'm wondering like how the stimulation device would work for somebody who doesn't have a regular cycle or cannot have a regular cycle for that reason.
For sure. So the people that I'm talking here, like the percentages, are from our general users. So we have no requirements on them. They can be on whatever they want to be as long as they don't have contraindications. In our clinical trials, they're off everything except from IUDs. Like if someone has an IUD, then we definitely include it. But I think the bit that is important is we can treat PMDD and PMS because they're brain-based conditions. We never claim to treat pain or treat endometriosis or whatever. We manage pain associated with endometriosis and specifically chronic pelvic pain associated with endometriosis. What I mean by that is that we change the way that it impacts your quality of life. So we don't deal with the lesions and ultimately you might need surgery, but what we deal with is actually a ton of women that we know, and a lot of our users will be on other things, but they still experience pain. So you can be on whatever you want, but if you still have that chronic pelvic pain, you are a good user for us because it means that whatever you're using is obviously not working and you're seeking supplementary options. And in fact, we're an amazing option for people as a supplementary option because we don't interfere with drugs, we don't interfere with hormones, we don't interfere, let's say, with the efficacy of your pill if that's another cycle suppression mechanism you're using. So it's actually specifically because of those comorbid or because of those other management tools that people turn to us as well for managing these symptoms. I think, and this could be a much longer discussion, and I actually have a talk on the neuroscience of endo, so if you want, happy to share that with you as well. But one thing that's fascinating is essentially there's 3 levels of pain: neuro, like localized pain in the place where it hurts, then kind of peripheral pain around that area, and then what we call like nociplastic or that central sensitization pain. And that's the pain that's responsible for when someone with endometriosis undergoes a surgery, so literally removes the lesion that causes the endometrial symptoms initially and still experiences pain. That's actually a super common profile for our users because they're like, I underwent the most severe treatment, but I'm still experiencing pain because it's at the level of brain. So that's what we manage. So again, we don't treat endometriosis, but we are a management tool for chronic pelvic pain associated with endo. And in our clinical trials, we make sure that everyone's on a stabilized routine for at least 6 months leading up to it and still experiencing pain that's severe enough to impact with their everyday functioning.
Okay, see, thank you.
Hi, thank you so much for the conversation today. My question is based on when you say you personalize therapy based on the patterns and based on the cycles and everything, I want to know how much of a factor age is. If you've come across anything interesting between women of different age groups, and as in when you age, obviously the hormonal levels and everything that you're dealing with, and even the default mode network and the salient network goes through so many changes. I'm just curious to know if you had any striking factors that you came across in terms of age groups itself.
That's a great question. To be honest, so in our sample of around 1,000 women on which we trained our initial kind of algorithm, not yet, but what we do see as a general pattern is that PMS symptoms, so the mood symptoms, do get worse with age and they do get worse with pregnancies. So while women in their 20s will most commonly complain of pain severity being an impact on their lives, pain seems to become, at least among our users, less of a factor, but mood becomes much more of a problem in 30s and 40s. It could be that it objectively gets worse, or it could be that the pain gets a little bit more managed, or it could be that you're just more sensitive to your environment and whatever you're managing. It could be perimenopause has an impact there. So we definitely see the effect of the types of symptoms that people get along the age, but we don't necessarily see that would yet impact the efficacy of the protocol we prescribe more so than anything else we treat, which is the severity, the diagnosis, and stuff like that. One thing too, referring to the couple of questions earlier, is that the conditions we deal with are often underdiagnosed. So it means that sometimes that, like someone who is older is more likely to know what condition they have because they've spent all the years trying to diagnose it. And so we have a lot more data so we can personalize a little bit better for them. And we generally notice that actually younger users come in with less data, ironically, which actually was not what I expected because I thought that young women are more cycle aware and whatever, but older women have lived with their cycles for longer, so they know the patterns a bit better. So we see a lot of age-related trends, but I think at the protocol personalization level, they haven't necessarily been the driving factor of our kind of models so far, more dominant than anything else. Yeah.
I think there was a question up here.
Yeah, choose your own adventure question, language of thought, premenstrual emotion, or transcranial stimulation methodologies.
Ooh, all are fun. I mean, let's do transcranial stimulation methodologies. Yeah.
Cool. Yeah. So I've read up on most of like the magnetic studies. It seems maybe every like quarter somebody talks to me about a new modality that's in a research phase. I'm wondering if there are any new interventions for cranial stimulation that excite you particularly.
Yeah, all of them. I mean, essentially, brain stimulation can be broadly divided into these two categories, invasive and non-invasive. So stuff you put in your brain and need a surgeon for, and stuff you don't need a surgeon for and you put on top of your brain. As a general rule, everything that you put on top of your brain, you need to assume that it barely reaches the brain. Like it maximally goes 1.5, 2.5 centimeters into the brain. So relatively superficial, which means it can only impact directly cortical areas. So it means if you're trying to deeply modulate some core emotion of who someone is, deep in their limbic system, a non-invasive method will not be the right place to do that. But if you are looking for something like top-down emotional management, which is like stuff that we do, that it could be effective. So I think that's kind of one of the bits around that. When it comes to non-invasive brain stimulation, I think the most exciting technologies over the last year have been things like focal ultrasound and non-invasive ultrasound ways, and then all different kinds of using transcranial direct or alternating current stimulation and stuff like that. The way that I approach it is that none of these are mainstream just yet. I think TDCS so far is the most studied one, and that's actually why we picked it, because we wanted something that could impact women's lives sooner rather than later. And we actually studied about 4 different modalities when we were choosing which methodology which technology, I guess, to employ. And we chose to use the best studied one because we knew that regulators still hadn't studied it. People hadn't studied women's health. It's going to take a while to adoption. So the more data that we can work with, the better it is. And frankly, in our experience, the difference was very marginal. So we chose kind of familiarity and evidence-based over something being like very marginally better, because we know that we can make a lot bigger improvements by personalizing the protocols, which you can only do with data. So we prioritize that over how cool or sexy a new modality sounded, because fundamentally they operate in a very similar way.
Thank you.
Of course. Maybe one more question.
Thank you. Sorry, I missed your beginning of the session, but I have 2 questions, if I'm allowed. First one is, how do you actually monitor the pain response? And then the second one is, have you noticed any headaches, let's say, for the women who wear these wearables?
Sure. So on pain monitoring, there's some things that we do in clinical trials and then some things that are feasible in the real world. So in clinical trials, the state of the art, so the standard that is required by regulators and et cetera, is actually the VAS scale, or the visual analog scale. Does anyone know what a VAS scale is? Cool. So it's a smiley face. It's essentially like how, on a scale from sad smiley face to happy smiley face, and how much pain are you? That's what the FDA requires to approve every painkiller that is on the market, and including ourselves as well. So that was a bit of a surprise. So we went a step further. So we have the VAS scale, which is the standard. We have an NRS scale, which is a numerical rating scale, which is 1 to 10 instead of smiley faces. And then we have a cold test. So at which point do you perceive the water as to be too cold? Then we have an algometry test, so pressure test. So at which point do you perceive that the pressure becomes pain? So if you think about it, pushing like a finger against your skin, and at some point you will say, ouch. So we wait for that method, and that way you know whether the threshold is higher or lower. So we use these 2 objective measures and 2 subjective measures. But just so you know, if we are not from the pain field, subjective measures are kind of the state of the art, and still to this date, because it's so ambiguous. When it comes to the way that we measure it with real world users, it's reported pain. So we kind of have a 1, 2, 3 pain. You can also add your own criteria, but it's kind of what people input, kind of like a period tracking app. And we're just like, how is your pain level? So it's a scale of 3. But obviously that's not clinical trials. And then on headaches, so yes, a transient headache is actually one of the mild side effects that are observed with this technology. So about 1% of users will experience a transient headache, which means it passes within 30 minutes of use. What's interesting about those headaches is you can't really predict who gets them. It's not necessarily people who have migraines and whatever. It's just people get them randomly, and not the same person. Like the same person might get a short headache, but it might not happen the next time they use it. So seems just like it happens from time to time. What is more interesting is that a lot of our users have reported that it actually improves chronic migraines. And so we actually now have a clinical trial running with NHS Trusts in the UK that essentially is studying the benefits of this for chronic migraines as well as for premenstrual migraines, which is migraines in the 5 days leading up to your period. So yet TBD whether that has a statistical level and like whether that makes a massive difference, but more people have reported improvements from migraines than have reported the side effect of a headache.
All right. On that buzzer, that is the conclusion of our conversation tonight. Everybody, another round of applause for Em.
Thanks so much, everyone, for coming along.
And feel free, of course, to stick around after, hang out, and hopefully see you guys at the next one. Thank you.